friends. Wish you all a very happy new year, albeit a bit late. Friends, today I am going to talk about how to examine a thyroid patient. How to examine a thyroid swelling. That's very important. Most of my students make the mistake during their viva or practicals examining the thyroid gland from the front. Whenever you are palpating, you have to do it from behind the patient. That is very important. You can inspect the thyroid gland from the front, but when you are palpating, it should be from behind. That's the number one thing you should always remember. Once you inspect the thyroid glands, normally located just below and on lateral side of the thyroid cartilage, usually weighing around 20 to 25 grams. And if it is visible, that means it's definitely enlarged. Normally it is not visible. You have a look, turn the patient to one side and the thyroid will be prominent. Ask the patient to swallow, then also you can see thyroid gland. That is how you have to inspect, see the surface of the thyroid and see any enlarged veins or vessels around it, something like that. And as I have said, the actual palpation should be done from behind. You have to see the location as you have seen in the inspection, find whether there is a local tenderness. Tenderness means viral infection. Could be thyroiditis due to some other cause also. Local warmth, temperature is increased or not, like in Graves' disease. Okay, normally the temperature is raised. Tenderness, the size, is there any nodules, like multinodular goiter is there. Multinodular goiter is likely to convert into carcinoma. That's how the thing. And otherwise you see any smooth thing or any variegated appearance, those things you have to palpate and find out. And you can assess the size of the thyroid gland also. But once the most important thing is knowing the primary toxic features. And normally you have to see whether there is any tremors and the moist skin. Skin is warm and moist normally. And are there any arrhythmias, palpitation, tachycardia, such thing? And most important, eye sign. That you should not just miss. What is Mobius sign? And when the thyrotoxicosis is there, the convergence is deficient. That is Mobius sign. What is Griffith sign? Everybody knows Vaughan Griffith sign. The lid lag, when you see downwards, the upper lid lag. Griffith sign is exactly opposite of Vaughan Griffith sign. That is lower lid lag when upward gaze is being done. That's very important. And as I had mentioned, you have to palpate and examine the patient from behind the patient, standing behind the patient when the patient is seated. That is Neff-Ziger test. What is Neff-Ziger test? When you are looking down from behind the patient, there is exophthalmos. The proptosis is visible because of exophthalmos. That is Neff-Ziger test. If you say this, that patient examiner will be very happy. Jaffray's sign is again very important. The wrinkles on the forehead is missing. That is Jaffray's sign. And always remember that when we are doing all these tests, there is one more test of lid retraction, that is Dalrymple sign. When the lid retraction is there, scleral, the borders are very clearly visible, that is Dalrymple sign. As I have already mentioned, Vaughan Griffith sign is the upper lid lag when you are looking downwards. These are the things, and ophthalmometry also can be done. And have you heard of Bruit? B-R-U-I-T. Everybody pronounces that Bruit. Somebody say Bruit, T is silent and such thing, but actually it's pronounced as if it is Brute, B-R-U-T-E. Although the spelling is B-R-U-I-T. You have to auscultate the thyroid gland when vascularity is more, especially in Graves' disease. you can feel the thing, and if even you can diagnose Graves' disease even without auscultation with the stethoscope, just by palpating, feeling the thrill. That is sign of, as I said, bruit, B-R-U-I-T. It's not bruit or bruit. Okay, thrill has to be palpable. Okay, that is the trick. And there could be Horner syndrome also. Whenever Horner syndrome, many people say it is exophthalmos. No, it is not exophthalmos, it is enophthalmos. And ptosis, they say, students. It is not ptosis, it is pseudotosis. Meiosis and hydrosis, everybody says the answer. And there could be deviated trachea, especially in X-ray finding. That's very important. You should. And one test that you should never forget, that is Cocher's test. This is not Kocher test or whatever. It is Cocher's, K-O-C-H-E-R. Cocher's test has to be performed to know the hyperthyroidism. Hyperthyroidism means if the T3, T4 are produced more by the thyroid itself, and it could be the metabolic syndrome is known as toxicosis. Okay, it could be primary, secondary. Primary means if it is happening because of thyroid gland production of hormones excess itself, directly related to thyroid itself. If you are giving levothyroxine or because of TSH stimulation, extra thyroid hormones are being formed, that is known as secondary thyroid causes. Now coming to Cocher's test, when you are suspecting tracheal obstruction, press the thyroid lobe over to the trachea, and the patient will have difficulty of breathing, or they can produce stridor. That is Cocher's test, the typical hyperthyroidism. Okay, there is one thyroid Cocher's sign also. You ask the patient to forcefully look upwards. They will be, convulsing, upper lid will be convulsing and coming down. That is thyroid. That is Cocher's sign. That is also positive in hyperthyroidism. So, have you heard of Berry's sign? When the carotid pulse suddenly disappears, is not felt, or with palpation during thyroid enlargement, that is known as positive Berry's sign. And one test will be definitely asked by the externalist, Pemberton's sign, that everybody knows. When the hands are raised, that there will be flushing and redness over the upper thorax and the face when the hands are raised, because of the obstruction due to the retrograde enlargement of the thyroid. You can do percussion also on the manubrium sternum. That also suggests retrosternal extension. And as I mentioned, give a glass of water and ask the patient to swallow, and palpate with both the thumbs on the lower border of the sternum. You can see the movements of the thing. If you can feel the lower border of the thyroid, that means it is not retrosternal goiter. It is not retrosternal. Otherwise, you should know how to palpate and see the mobility if it is feel. Now, all the hard nodules need not be malignant. Even because of calcification, thyroid can be hard. Okay, so that's very important. And you should know how to do Leher's test, and there's one Kreil's test. Have you known? Do you know Kreil's test? Kreil's test is when you are using both the thumbs and asking the patient to swallow. Then palpate the size of the thyroid nodules and whether it is palpable or not, how it is moving and all, with both the thumbs. That is Kreil's method of placing the thumbs on the thyroid gland and asking the patient to swallow. That is Kreil's method. And most important is, very simple, examiner always asks, is Leher's test. Leher's test is nothing but putting only one finger on the side of the thyroid gland, pushing to the other side. If it is prominent, yes, thyroid is enlarged. Thanks for patient listening. I hope it is very, very informative. Have a wonderful day and Happy New Year once again. This is Colonel Pradeep Pendyala, Professor of Anesthesiology from ASRAM Medical College, Eluru City of Andhra Pradesh, India. Take care. Bye-bye.